This morning I had a planned procedure at the Gertrude Children's Hospital in Nairobi. This is a 16-year-old boy who came to see me about 4 weeks ago with complaints of pain in his left knee. He's a sportsman in school. He loves to play rugby, football, but over the last 3 months or so he's been getting a lot of pain, particularly after exercising or when he bends his knee. That was the main complaint. So when I examined him, main findings which one would pick out is when you attempt to bend the knee, we call it flexion, he would get a lot of pain in the initial phase of bending that knee, and particularly when you twist the leg or the foot to be in an inward position, we call it an internal rotation. Now that has been described as Wilson's test. It's so typical of a condition which we call osteochondritis dissecans, which is an articular cartilage disease, which is primarily because of bone disease, whereby the bone undergoes what we call necrosis. In other words, it dies. There have been so many theories about why that happens, but the net result is that you have a defect where there is no cover or cartilage, and as a result of that, these patients experience a lot of pain because there is contact of the raw area of bone against normal part of the knee. There's a particular point of the knee which we call it the tibial spine. Is more of a protruding area, so that spiked area you'd normally would get into contact with that point where there's deficiency of bone, and that's what causes a lot of pain. That is from the examination and physical examination and a bit of the history that we get from the child. There are ways to try and confirm this diagnosis. The initial test, as usual, and simplest test that you do is an X-ray. That on occasions may show you an obvious defect where you can see there's some sort of a dimple into that area of the bone, or it might actually be a loose body where the part of the cartilage completely dissociates from the bone and you can see it as a loose body within the joint. If you look at the knee joint is made of 3 bones. You have the femur, which is the thigh bone, you have the shin bone, which is the tibia, and then we have the patella, which is what we call the kneecap. Those ones will form the knee joint. So in this case, the problem was in the thigh bone at its point of articulation, means where it forms a joint together with the tibial bone, and it was on the inner side. And it is known that in almost about 85% of the time, that's where this lesion will be. So what we find on examination is you'll see either you may find the cartilage completely sheared off from the bone so that you can see a bony defect, or you may find something more like a bubble. It's lifting off of the cartilage, which is not normal compared to the rest of the surface of that bone. And that, knowing where it should be and also being able to demonstrate that bubble, shows you that we have a disease process in that area. So what we did was to completely cut off that area of the cartilage which was damaged, leave the bone raw, trim it nicely so that we have a smooth area around the defect. And the next thing we did was what we call microfracture, going in with a sharp instrument and making several puncture holes at about 5 millimeter distance apart. The entire area which was damaged was not very large. It was about 10 millimeters by 8 millimeters in size. And so we were able to make the microfracture, at the end of which we did a procedure of platelet-rich plasma therapy. What that means, we take a patient's blood from any part of the body, the limbs mainly, from his elbow area where we take what we call the venous blood, Then we take it into a machine that does spanning and separates various layers of blood, and in particular we are interested in the plasma area, meaning the fluid area, which is known at the evolutions in which we do the spanning of that blood. We're able to concentrate quite a lot of platelets, and then we go and we deposit the platelets exactly where we have created that defect by way of removing the cartilage that was there, and so allowing new cartilage to form. So we do hope in so doing this young man should be able to have coverage of that defect on the bone, and his pain should be able to go. Averagely within 3 months, we expect him to clinically show that he's in less pain, he's able to do a lot more activity than he was doing before. But for one to go back into sports like what he was doing before, we have to give him about 6 months.